Bismillahirrahmanirrahim. Assalamu alaikum. Welcome to the first event of the Rawalpindi chapter of the Pakistan Cardiac Society. The talk today will be delivered by my colleague, Dr. Farahe. He is an assistant professor of cardiology at Rawalpindi Institute of Cardiology. And the title of today's talk will be Dyslipidemia, Novel Therapies and New Emerging LDL Cholesterol-Lowering Strategies according to latest guidelines. This is under the supervision of our course director, Professor Dr. Syed Tahir Shah, who is Vice President of the Pakistan Cardiac Society. My name is Dr. Qurban Khan. I'm an Assistant Professor of Cardiac Electrophysiology at the Rawalpindi Institute of Cardiology. Today, our panel of experts shall be Professor Major General Suhail Aziz, who is an interventional cardiologist and president-elect of the PSIC and ex-commandant of AFIC, Professor Muhammad Hafizullah, who is ex-VC Khyber Medical University and Chairman Board of Governors PIC Peshawar, our General Secretary of the Pakistan Cardiac Society, Professor Dr. Fawad Farooq, will be joining us. Professor Brigadier Retired Dr. Abdul Hamid Siddiqui is with us. Dr. Talha bin Nazir, who is Head of Electrophysiology at Rawalpindi Institute of Cardiology, will be joining us. And of course, Dr. Hamza Azhar Ghori, who is an Assistant Professor of Cardiology. He will also be with us as a panel on the panel. So we will begin this talk. Dr. Ali will speak for 30 minutes. And after those 30 minutes, we will open the floor to the panel and any questions that anyone may have. I give you Dr. Ali Farahe.
Thank you. Can you listen to me?
We can hear you just fine. Can everyone mute their mics, please, so that we don't get any interference?
Thanks for the kind words. I would like to express my sincere gratitude for all of you in joining this session. And a special thanks to all the expert panelists. My name is Dr. Ali Farahe, and I am working as Assistant Professor of Cardiology at Rawalpindi Institute of Cardiology. And the topic for today's discussion is dyslipidemia, novel therapies and new emerging LDL cholesterol lowering strategies according to latest guidelines. So without further ado, I would like to dive into my first scenario. It's our typical patient, 76-year-old obese hypertensive male who presented to ER with anterior STEMI. He was managed with primary PCI to LAD with drug-eluting stent. His first lipid profile was sent and we showed an LDL level of 65 milligram per dl. So what points will we consider in the cholesterol management of this patient? So first of all, we have to realize that this patient is for secondary prevention. He already had an event, which is the STEMI, and his LDL level is 65. So my today's topic, I was given the difficult task of simplifying these very difficult guidelines. I have taken most of my material from the ESC guidelines, but I had to borrow some snippets from the ACC guidelines as well. So this slide is basically the most important slide of this presentation. In ESC guidelines, the management of the patient, it depends upon the risk stratification. And for these, we have 4 risk categories: very high risk category, moderate risk, and the low risk. These risk categories, in contrast to the ACC guidelines, are then coupled with the LDL levels. And these are the presenting LDL level without any treatment or the treatment he was taking before. So these are again subdivided into 6 classes, starting from 55 up to 190. So these 2 things are then combined to make a decision regarding the management option, which could be the lifestyle only changes, lifestyle followed by the consideration of the drug therapy, and upfront treatment with lifestyle and drugs. So treatment is started, and then this guideline gives us certain pointers about what goals to set and how to follow up these patients. So our patient, as I discussed, already had a STEMI, so he was enrolled for the secondary prevention. And for these patients, if the LDL is above 55, you have to start upfront lifestyle intervention and drug intervention. Some of these patients, which are very little, who have had LDL level below 55, those are the only group of patients which can be managed first with the lifestyle and then started on drugs. But obviously, if a patient had and ACS and STEMI before. So those guidelines give class 1 indication for lifelong statins. So what are the lifestyle modification? They include smoking cessation, healthy diet, physical activity of at least 30 to 60 minutes per day, a BMI of 20 to 25, a blood pressure of less than 140/90, and HbA1c level of less than 7. So what dietary modifications should be done? So these are the foods which are preferred to lower the cholesterol. They include our vegetables, most of our fruits, non-caloric sweeteners, fish, poultry without skin, skimmed milk, and the best method of cooking is grilling, boiling, or steaming. These are the foods that must be taken in moderation, which include bread, rice, pasta, potatoes, dried fruit, and then beef and lamb. They also must be used only in moderation. And all oils are included in this category. And better method of cooking is stir frying and roasting and air frying as compared to the frying. So these are the foods that must be used sparingly, which include pastries, muffins, cake, whole milk, cheese, trans fats, margarines, butter, ghee, which is a type of the butter, and coconut oil. And the worst method of cooking is frying. So these are certain lifestyle modification that must be started in these patients. So first line treatment for all such patients are statins. Statin reduce HDL by up to 50%. They reduce triglyceride by up to 10 to 20%. They elevate HDL as well, and they only have marginal effect on the lipoprotein little a. So now I will come back to the same patient again, but meanwhile, I have another patient. This is scenario number 2. He's a 45-year-old male. He had 11-year history of diabetes, which is well controlled, but he has a family history of premature coronary artery disease. His LDL is 95. So how will you risk stratify this patient? So he falls into the very high risk category. So these are the patients who have had recent documented atherosclerotic cardiovascular event, diabetes with target organ damage, or at least 3 major risk factors, family history with atherosclerotic disease, and with the presence of another major risk factor. So this is where our patient falls. Severe CKD patient, they are also very high risk category. And then we have a calculator, which is the SCORE2 system, which is recommended in the ESC guidelines for identifying or for calculating the 10-year risk of the fatal CVD. A patient with a score of more than 10 is placed in this category. So how to manage these patients? I have just simplified the slides, and on the basis of the initial LDL, if the initial LDL is less than 55, this patient must only be prescribed lifestyle interventions. If the LDL is 55 to 70, then lifestyle intervention must be initiated first, followed by the drug intervention. And an LDL more than 70 entails upfront treatment with drugs and lifestyle modification in this category. So I will quickly jump into my third scenario. Again, the same patient, just assuming. He had history of family history of premature CAD, but he has no other major risk factor like diabetes.